Welcome to EuroPCR 2024. We're here today to talk about the Landmark randomized trial. My name is Andreas Baumbach. I was the global PI, and I'm here with Professor Patrick Serruys from Galway in Ireland. He was the chairman of this, is the chairman of this important trial, and Professor Niels Van Royen from Nijmegen in the Netherlands, who was the top enroller. Let's kick this off. Patrick, why did we need the Landmark trial?
Good question. I think that the standard was the Evolute and the Sapien in the field with a lot of evidence. There was a lot of observational study with the Myval series, but no randomized trial. So that's novel balloon expandable device has to prove its capability in a randomized trial. So that was the randomized trial.
And how was it executed? I mean, give us a rough idea of the methodology.
Yeah, it's classical. When you do something head-to-head, you have to go for non-inferiority. And they achieved non-inferiority quite easily. I mean, there was in favor of the Myval series less than minus 2.3% of event, and it's a composite endpoint with 7 items. That's VAR3, very demanding composite endpoint. And they achieved that, minus 2.3, that means in favor of Myval. So non-inferiority was there with a p-value 0.0001.
So, nailed it. But how was your clinical experience? You enrolled more than 100 patients. That means you now have a good clinical experience with this new system. Can you tell us a little bit about your experience within the study?
Yeah, so I think in general the experience is very good. It's a very straightforward system, dummy-proof, I would say. So it's pre-crimped, it's flexible. Well, it's getting close to a PCI procedure. So in that respect, I think they did a very good job in the design of this valve. Of course, and that's why we were so eager to enroll so many patients. As Patrick said, we need these kind of studies. We need these head-to-head comparisons. And the field has evolved. The standard is indeed Sapien and Evolute. And I think all other competitors have to show equivalence or maybe even superiority against those two standards. So in that respect, I think it's important. That's why we try to enroll as many patients as possible.
Yeah, congratulations again. That was really a great effort. Very welcome and contributing to this study. Patrick, a bit more about the results. Are there any details that are of interest? Because we've got a composite endpoint of 7 items, right? What is of interest for the audience?
Before going to that point, we have to say that that technology has an edge on the other in the sense that they are intermediate size, and that's very important. It's a novelty in the field. It's a small step of 1.5, so that you can really adapt the device to the anatomy. And it's a non-inferiority, so in terms of mortality, no difference. There was a small advantage for the contemporary comparators in 2 fields, but in 3 important fields, which is pacemaker, PVL, and vessel damage, I would say, introduced, there was a small numerical advantage for the Myval. So that explained the small difference of 2.3%. Yeah.
So we can summarize really here. This is an important trial. It's a randomized comparison of 3 valves. The focus is on the Myval THV technology, which is novel, which has interim sizes, 1.5 increments, which allows for more accurate sizing. And what we haven't mentioned now is that it also shows superior effective orifice areas on echoes.
Andreas, let's talk about
Throw that in. Explain that.
Yeah, I mean, that came a little bit as a surprise because, you know, you could say it's a Me Too trial, non-inferior, that's it. but you have this capability to adjust the valve to the anatomy. And then we were surprised to see that the effective orifice area versus the Myval was identical for the 20 millimeter, but then systematically for the 23, 26, 29
versus the Sapien.
Versus the Sapien, there was an advantage, a significant advantage in the effective orifice area. Yeah. And then the big question is that going to have an impact on the durability? Is going to have an impact on the long-term clinical follow-up? That's the big question. And the other amazing aspect is that for the 26 and the 29, we were at the same level of effective orifice area with the Evolute.
Yep. I think that might be especially interesting for the small annuli. So after the SMART trial, we've seen how important it is to look specifically at this cohort of patients. We had a large number of small annuli anatomy in the Landmark study, so that will allow us to look specifically at that.
One third was below 430 millimeters square.
Yep.
1/3.
And another aspect of the valve, I think that makes it also, well, a little bit different from available platforms is that you have also the very large sizes. They were not in the Landmark. There was a separate nested registry. We will see data on that later. But for the extra large sizes, you have the 30.5 and the 32 millimeter valves. And
so what is your takeaway?
My take is that we've seen a really robust randomized trial. I mean, we've been working on that for the last 3-4 years.
Together with you.
Niels, you mentioned in your presentation how many data were required and were assessed. We now have 30 days, and I think there is no doubt that this valve system has proven safety and efficacy in the first 30 days, but I have no doubt that this will translate into future benefits, I would hazard a guess. And we will see the results in 6 months, 1 year, 5 years, 10 years from now, and we will follow these patients closely. I think this system has arrived in clinical practice backed by this fantastic randomized trial.
And by the end of this year, we will also have data of the COMPARE TAVI from the Danish colleagues, another 1,000 patients with this system.
That's important.
Which will add.
So we will reconvene in PCR London Valve for sure.
Well, gentlemen, thank you very much for this brief look into the Landmark randomized trial.
Thank you.